Good morning. Great to see everybody. It's my pleasure to introduce our grand round speaker today, Kate Burdick, who joins us from Harvard University. Kate did her undergraduate training at the University of Rochester and then graduate school at the City University of New York, and postdoc at Yale, and then joined the faculty first at Einstein College of Medicine and then Mount Sinai and then at Harvard University. She's been incredibly prolific as a researcher. She has over 140 peer-reviewed publications. She's had a slew of NIH grants. She's currently the PI of 2 R01 grants, and she's really done quite a great deal of mentoring and has won awards for that, and also won the coveted Colvin Award for achievement in mood disorders research from the BBRF, the Brain Behavior Research Foundation, I think. So it is my pleasure to welcome Kate to speak to us today about her area of expertise, which is cognition in bipolar disorder.
Thank you, Andrew. Can you guys hear me okay in the back? Okay. And thanks so much for the invitation. I love the city of San Francisco. I'll tell a little anecdote about when I first fell in love with it, and you can gauge my general taste in places and why I like or don't like places. But very early, when I was probably in my early 20s, I had friends living here, and so I came here frequently. And the thing that impressed me the most was somewhere, I think around Grant and Green, there's a laundromat that I went with one of my friends where there's a bar and a pool table in the laundromat. And I thought, this is a genius city. This is brilliant. Why is this not every laundromat in the United States? So that's why I love San Francisco. I'm going to talk today about bipolar disorder a little bit more broadly and talk about why cognition is such an important core feature of this disease. It's applicable to many of our psychiatric diseases. You'll hear me focus primarily on bipolar disorder, but many of these things hold true across schizophrenia, other major mood disorders, and other psychiatric illnesses. So here are my disclosures. I'm not going to be talking about anything for any paid positions that are listed here. Okay, so I'm just starting, and I'm sure everyone here knows these horrific numbers in terms of what bipolar disorder looks like. Bipolar disorder itself has two primary subtypes, bipolar 1, where there's a full-blown acute mania in addition to intermittent depressions, and bipolar 2, which has lower grade mania, known as hypomania, of course, and with also the same level of depression, if not more. These two disorders together account for about 3% prevalence of the adult population, which is 40 million people worldwide. There are immense disabling aspects to this disease. So fewer than 50% of our patients with bipolar disorder will fully respond to treatment, have found treatments that work well for them. There are horrible side effects to many of the medications, and many are just not effective for about half of our patients. Unfortunately, it takes about 7 years to get to a correct diagnosis for most patients with bipolar disorder, who present first with depression and then go on and are sometimes exposed to antidepressants that can trigger mania, but 7 years of improper treatment on average. And all of these things together, along with some of the comorbidities that I'll talk about today, results in a 10 to 20-year decrease in life expectancy. And so this is really obviously a horrible, disabling disease. Financially, it represents a massive burden of, on average, $200 billion a year in the US alone. So this is really an important illness to think about and to study to try to get improvements in care and really get people functioning back in their lives. So why are these numbers so dismal? There are a number of very clear challenges to progress in the space for bipolar disorder. Again, many of these apply to all of our other psychiatric illnesses as well, but the heterogeneity within this disease is profound, and I'll talk a lot about heterogeneity today and how we might leverage that to understand the disease better. Comorbidities are also unbelievably common in our patients with bipolar disorder, both psychiatric comorbidities as well as medical comorbidities. And it has a dynamic course. So by nature, it fluctuates between illness, where we have acute manias, acute depressions, and then periods in many patients of relative wellness, but not all patients. And so this course, the dynamic nature of the course is in large part why it takes so long to get the right diagnosis, because we see people cross-sectionally and have to follow them over a long period of time before the disease really expresses itself properly. So heterogeneity itself is built into the way we diagnose most of our psychiatric illnesses. We use checklists. You're all familiar with the one that's shown on the left side of the screen here, which is the checklist for a diagnosis of acute mania, bipolar 1 disorder. These diagnoses within the DSM are categorical, so you either have the illness or you don't have the illness. There's no dimensional aspect, despite the fact that we know most of the symptoms that are presenting are dimensional in nature. And moreover, these are not biologically based. So the symptoms that you see here are really largely based on self-report from patients and sometimes observations when you're seeing the patient in your office. But really the description and the list here was not developed in any way based on anything we know about the biology that underlies this illness. Clinical presentations vary really widely because of this kind of checklist. And so I'll give you the example that if a patient walks into my office on Monday morning and they report the primary need, the required element of A, criterion A, elevated mood, or increased energy accompanied with irritable mood, plus any three of the other symptoms. So say this patient walks in and reports elevated mood, symptoms number 1, 3, and 5, leaves my office with the diagnosis of acute mania, bipolar 1 disorder. Later the same day, a person can come in and report irritable mood, increased energy, symptoms number 2, 4, and 6, walk out of the office with the identical diagnosis, but not a single symptom overlaps between these two individuals. This is really profound. And what you see is about somewhere above the number of 100 when you do the math to see how many different ways can someone get a diagnosis of this illness. And so this results in inherent heritability, heterogeneity. It's also heritable, but that's a separate thing. Heterogeneity within the way that these people present. And so not surprisingly, patient in the morning on Monday and in the afternoon on Monday are very unlikely to respond the same way to the same treatments. And yet in research in particular, what we have tended to do is use what's called the case control paradigm, where you take all bipolar patients, you lump them together, and you compare them with healthy people. And there are multiple reasons where that is flawed. The first is that it assumes that all bipolar patients are the same. It also assumes all healthy controls are the same. And it assumes that there is some special thing about healthy controls that is the optimal state of being. That dimensional component is lost as well. So this is really how heterogeneity has created the problem of understanding pathophysiology, because if they're not responding to medications the same and their symptom profiles look different from one another, there's a good chance that the causes and the things contributing to the illness and their outcomes are different between these patients. In addition to this heterogeneity, we see an exceptional complexity that's marked by multiple comorbidities. So some patients with bipolar disorder will experience psychosis during their acute episodes. About 50% of bipolar 1 patients do, but the other 50% never experience psychosis in the course of the disease. Substance use disorders are prevalent at about 50% of bipolar patients at some time in their lifetime, a full-blown disorder, as well as a full-blown anxiety disorder. Also, about 50% of patients with bipolar disorder will meet criterion for this at some point in their life. Childhood trauma is far more prevalent than it is in the general population. And sleep and circadian disruption is also a very clear present symptom, even outside of mood episodes for many, if not most, patients with bipolar disorder. And then medical comorbidities, of course, add to this picture. Cardiovascular disease, autoimmune, and other immune diseases are seen much more commonly in patients with bipolar disorder than in the general population. So this really makes for a very complex picture when we're trying to understand this illness and figure out how better to treat it. And then lastly, the dynamic course I already mentioned, but patients with bipolar disorder tend to fluctuate in their mood and on average change symptom status about 3 times per year. So there's a lot of dynamic nature to the patient. How they're doing now may tell you very little about how they're doing 6 months from now. Also, and this will be particularly relevant when I talk about some of the biomarker work that we're doing. There's increasing evidence that there's a cumulative burden of illness over time in patients with bipolar disorder, looking a little bit more like a neuroprogressive disease than we once thought it might be. And so this is believed to be related to the number of recurrences, particularly of acute mania, but also likely of severe depression. And that corresponds to very clear imaging data that suggests that there's gray matter loss in areas of the brain that are most vulnerable to stress. During those episodes, it's thought that there is loss of cells in the brain. And there are two primary hypotheses. I'll focus specifically on one of them. But one is a hyperglutamatergic state that's seen that is that causes apoptosis. Sorry, and the other is neuroinflammation, which is what I'll talk a little bit more about. But again, the data are suggesting that at least in some people with this disease, we see a declining course, and that is seen in cognition as well as in functioning. So how do we address these challenges? We can leverage these challenges. Think of this as a half glass full scenario where there are lots of groups around the world who are now using statistical approaches to try to identify homogeneous subtypes. And that's what I'm going to talk about today as well. And this is a new way to think about classifying people. So we acknowledge the heterogeneity, and we think about, if you look, let's see if I can get this pointer to do what I want it to do. Okay, that'll work. Here, what we see is in these boxes a representation of both within disorder heterogeneity and cross disorder overlap. So what you're seeing is the colors are representing a subtype. Let's think about of people who share certain features, and that's seen across the diagnosis. It transcends diagnostic boundaries, but it's also within each of these diagnoses you see that heterogeneity. The idea between these for these statistical approaches and what I'll talk about today is that you group these people together, you acknowledge that heterogeneity, and you do some statistical approaches to try to identify, are there homogeneous subtypes based on something that hang together? In this case, what's important is that this should be based on something that has to do with brain function. These are brain diseases, and those checklists that I showed you for mania are not getting at brain function. They're just simply behavioral outputs. And so if we can think about classifying people both using more homogeneous approaches, statistical approaches, and using a measure of brain function to see if we can identify groups such as these below that look more like each other, are more likely to have similar causal factors that go into the disease, and more likely to respond to treatment in a more similar way, we can start to make some progress in this area. So again, the focus on brain function should be dimensional. So we're thinking about something like cognition, which is what I'll talk about, where it ranges fully from abnormal to normal. And that's true across healthy people, across people with schizophrenia, bipolar disorder, and so on. And it importantly captures brain function in a dimensional way, not in a categorical way, in the way that we label disease. And then finally, I'll talk a little bit about some efforts. Most of the data I'll show you today is cross-sectional. I'll talk about some of the new efforts to really scale this up and think about this in a longitudinal way. So why do we focus on cognition? So cognition the way I'll describe it today is really a tool more than anything else. But the importance of cognition in the illness is clear. It is very specifically involved in the way we regulate our emotions. And so, of course, we know the primary feature of bipolar disorder is dysregulation of emotion. And we know that intact cognition, particularly in the areas of the prefrontal cortex, is really necessary to regulate the automated responses the brain is making down here. Let's see if, yeah, this is got right there in the amygdala and the limbic system areas. So what we see in major mood disorders is basically, and this is oversimplified, but an overactivation in limbic regions where the people are seeing the world in a more negative way than it actually is. So the stimuli that they're reading into the brain is being biased. And that overexpression of that from the limbic system in any other healthy situation, the prefrontal cortex would shut that down. In people with bipolar disorder and major depression, you see a combination of overactivation of limbic and underactivation of prefrontal cortical cognitive control regions that results not only in the onset of disease, but also in the recurrence of disease over time. The other reason why cognition is particularly important, and this is, I think, probably one of the more important one of the most important focuses here, is the idea that it is a very strong predictor of how people are functioning in the world. So while acute mania and psychosis are very in-your-face kinds of symptoms that we see in our patients when they're acutely ill, those are not the things that keep people from getting back to work when we're able to actually shut down some of the affective symptoms. One of the clearest predictors of functioning, both in schizophrenia, bipolar disorder, and in major depression, is persistent cognitive impairment that does not go away when we treat the manic symptoms. And so here is just a graph or a table on the World Health Organization top 10 causes of disability in the world. This is actually an old chart, but what you see pretty consistently every time they release these numbers is that at least 3 or 4 of the psychiatric illnesses will fall up on this list, alongside things like war, violence, and traffic accidents. So again, the disability is profound. On the right side of the screen, what you're seeing is a meta-analysis of the relationship between cognition and disability in bipolar patients. And I'll just draw your attention to the sort of center line, or I'll try to. The center line over here, anything to the, let me just point here, to the shift, it's not the black line, it's the blue line, and anything to the right of it suggests a significant relationship in each of these studies. And so very consistently, we see that this is a strong relationship with cognitive functioning and disability. And importantly, when we start to think about how we treat patients, again, acute mania, when it's a person shows up on the inpatient unit, there are priorities to shut down the symptoms that are most prominent. But those aspects of the disease tend to be relatively easier to treat. When you get those patients out, what we're really looking to do is to not just put a person into affective remission, but to really think about recovery and getting people well and actually thriving in their lives. So before I kind of launch into the cognitive piece of this, I want to just walk through a hypothesized trajectory of the way cognition develops and develops abnormally in at least 2 major psychiatric illnesses. This black line, I'm not going to use this pointer anymore. The black line that is kind of going up and stabilizing is healthy individuals. So what we know is that people's cognition develops over childhood and into adolescence. That's a normal developmental trajectory for cognition. It stabilizes in early adulthood and really doesn't change very much unless there's dementia or some other particular hit to cognition. In individuals, if you look at the dotted line, who develop schizophrenia, what we see very clear evidence is separation from their peers as early as you can measure cognition. So in people who develop schizophrenia, where you're seeing the vertical dotted line at the point of first episode, they show very clear cognitive impairment well before they actually show any symptoms of the disease. Just before they have their onset of the first psychotic episode, you see a dip in cognition that's consistent with the prodrome of schizophrenia, some social withdrawal, but very clear deficits in cognition. There's a drop. And then after the onset, a slight drop, but then it mostly stabilizes over time. It's a stable deficit relative to healthy people that you can see. So this is one of the clearest bits of evidence that there is that schizophrenia is a neurodevelopmental disorder. It's related to impairment in the brain function very early in life, and that you can see that even on cognitive measures. What we think we know about bipolar disorder, and I'll show you some evidence to support and to counter this, is that most people with bipolar disorder will show a normal cognitive trajectory. That's the gray line that you're seeing here. And that up until the point of the first episode, specifically the first episode of mania, it's normal cognition. And then you see a drop in cognitive functioning just after that, but some recovery in cognition when the affective symptoms are remitted. And then another drop, and then another drop. And you see a kind of wavy line that looks like neuroprogressive disease. This isn't linear, so it isn't like Alzheimer's disease where duration of illness is predictive. It's really what those arrows are indicating are the numbers of episodes people have. And so those episodes there are related specifically to acute mania. And we think that something is going on in the brain of people with bipolar disorder each time they have a severe episode. This is that same figure I showed earlier, but what what it's really pointing to is the idea that each time a person goes into an acute episode, you see an upregulation of things like pro-inflammatory markers, you see downregulation of neuroprotective factors, all in response to what we see as a normal stress response in anything. And when you've seen people with acute mania, it's very clear that they're undergoing a lot of stress, both peripherally and centrally. And what is thought to happen during the changes that are happening peripherally, which is mostly what we've been able to measure thus far in the field, is that inflammatory markers get into the brain. And when they do, they activate cycles that will put cells at risk of cell death. That cell death occurs in areas of the brain, such as the hippocampus, prefrontal cortex, that are most vulnerable to stress. And that kind of sets up a vicious cycle. Each time that occurs, the brain becomes more vulnerable, recurrence happens, and then you see this kind of cumulative effect over time once people have had multiple episodes. So what does cognition look like at the group level? When we think about bipolar patients versus schizophrenia patients versus healthy people, this is an old graph, but what you're seeing is the blue line are people who are healthy controls, and they have, this is on a T-score scale. So their performance is based as a mean of 50 and a standard deviation of 10. The 7 domains of the matrix are listed on the bottom, and these are just separate domains of cognitive functioning that we tested in these individuals. The red line are people with bipolar disorder during a remitted phase of disease, and the green line are schizophrenia patients during a residual phase of the disease. And basically what you see in this study and hundreds of other studies is when you compare bipolar patients with schizophrenia patients at the group level, you see that the shape of the curves are similar. Qualitatively, the deficits are similar to one another. But quantitatively, or more, and from a severity standpoint, you always see schizophrenia. The group of schizophrenia patients will perform worse. So bipolar here in the remitted phase are functioning about 1 standard deviation below where they should, and schizophrenia patients are closer to 2 standard deviations below average. So this is typical of what you see in most studies when you're looking at the group level. But I already mentioned heterogeneity is profound in this disease. And from a cognitive standpoint, what I haven't mentioned, and I don't think I have a slide in here, is that from a functional standpoint, you see this in the media, right? There are people with bipolar disorder who are CEOs of companies, who are functioning incredibly well, actually better than most people do in many instances. And then there are equal numbers of bipolar patients who are homeless and who are unemployed most of their adult lives. This was sort of the basis of looking at cognition from a heterogeneity standpoint. But what we did in this study was to ask the question, do all bipolar patients look like that red line, or are there subgroups? And so when we look at the subgrouping approach, it's hierarchical clustering. It's a very straightforward statistical approach. You take the scores on each of these 7 domains of each of the patients, throw them into an analytic process, and it addresses the question, are there homogeneous subtypes? And if there are, what do they look like? When we did this back in 2014, we got the answer of 3 subtypes. I'm going to talk about the newer data, so I'll only touch briefly on this. But what we found was that there was one subgroup, that's the purple line there, this we labeled as intact. And those individuals, relative to the black dotted line, show no impairment on cognitive functioning. In fact, that purple, the social cognition is significantly better than healthy controls. Again, likely mapping to that group of patients who are functioning better in society, even better than healthy individuals or non-psychiatric controls in many cases. That's about 30% of the cohort. And then the red line shown there is what we refer to as selective impairment, because they show deficits, but really specifically on certain areas, processing speed and attention, social cognition, but relatively normal functioning on memory and executive functioning. The blue line is of particular interest because we refer to this as a globally impaired group. And these are people who are functioning globally under the underperforming and at about 2 standard deviations below average. This is 40% of the sample. And they look, if you look at the yellow dotted line, that's the matched group of patients with schizophrenia. So cognitively, they look exactly like patients with schizophrenia. And what we really point out here is that some patients with bipolar disorder are impaired, some are not. And that real question became, we can identify these homogeneous subgroups, but can this approach tell us anything beyond that some patients are impaired and some patients are not impaired? Can it reveal anything new about the illness? And so that's mostly what I'll focus on for the rest of the talk. We took these data, the first group of data, used it as pilot data, got an R01. This is a second cohort, a completely separate cohort that I should have published paper on about 2 years ago. It's sitting in my inbox. Nonetheless, it's unpublished at the moment. And it's a larger cohort. We spent about 10 hours with each of these individuals in person, doing an enormous amount of phenotyping on these folks. We got blood, and so you'll hear about some biomarker work as well as many of the phenotypes, but not all of the things that we looked at specifically. The important question of once you've identified these subgroups, we replicated basically the same general pattern. The solution for the hierarchical clustering was there are 3 subtypes that differ from one another. We then ask what's different about these groups. Why are the people on the purple line doing so well and those in the blue line doing so poorly? And can it tell us anything about intervention? The first thing I show you just on the side are the things that are not different by group. And this is true in that first cohort as well. Somewhat surprisingly, bipolar 1 versus bipolar 2 it's distributed equally among these groups. Presence of psychosis history, equally distributed. Current symptom severity, these are all remitted patients, but even the sort of subsyndromal symptoms are similar across these groups. Importantly, duration of illness is similar. And in this cohort, the duration of illness is on average about 18 years. So they're well into the disease. And the medications are similar. So on average, they're taking about 2.5 psychotropic medications. This cohort has about 30% that are unmedicated, and they also distribute equally. So none of these things are explaining why someone lives on that purple line and another person lives on the blue line. When I'm going to show you how they do differ and what I think it's telling us about the illness, I'm going to focus first on the period that is before the onset of disease. I'll just remind you that what we think is true in bipolar disorder is that there's a normal neurodevelopmental trajectory from a cognitive standpoint. And when we look at the group level in the same cohort I just showed you, case control, just looking at all of the bipolar patients together and all of the healthy controls, that's what we see. We see no difference in premorbid IQ. This is a proxy measure of IQ, by the way. It's a hold measure that allows us to estimate how people's IQ would have looked prior to the onset of disease. It looks very much like the healthy control. So that matches with that hypothetical model. But when we look at the cognitive subgroups, we see a very different picture. You see that intact group is actually above average on premorbid functioning. And importantly, this blue group, the more globally impaired group, are significantly below healthy controls on premorbid functioning. And when we compare that with what we see in schizophrenia, meta-analytic data of the level of deficit premorbidly in schizophrenia, it looks exactly like this, suggesting there's likely a subgroup of bipolar patients that don't fit that normal model that we looked at and specifically have a more neurodevelopmental appearance in their phenotype. Other areas, kind of premorbidly, when we look at early life risk factors, we also see differences in our subgroups. So physical abuse, we use the childhood trauma questionnaire to look at severe abuse in childhood. Physical abuse is considerably higher in that globally impaired group relative to the others. And education is lower in that group, again, pointing to an abnormal developmental or premorbid phase in that group of patients. Again, about 40% of the cohort. I'm going to now move to the period, which I think is probably in some ways more important, in so much as that we can think about intervention is after the onset of disease. And reminding you again, what we think is happening is this kind of wavy line in bipolar patients relative to episodes. When we look at just a change score of premorbid functioning and current functioning as an estimate of cognitive decline in the whole group of patients versus controls, we see no evidence of change at all. Relative to healthy controls, you see this drop. I'll note that this is a mean of 100 and a standard deviation of 15. So this is a very, very small amount of change seen in both groups equally. This is actually consistent with all of the longitudinal data that we have, which is still limited. These are very small studies you're seeing here, but this meta-analysis looked at longitudinal change on cognition in bipolar disorder. And actually, if you see just to the right of the zero, the gray diamond at the bottom suggesting there's actually a little bit of cognitive improvement when you meta-analyze the data. So across these 20 studies that are longitudinal studies, there's no evidence of cognitive decline. So it doesn't fit with that model that I showed you earlier. But these are very small samples, and there's no accounting for heterogeneity within these samples at all. And so when we look at the cognitive subgroups and we do the same subtraction method, and we're looking, is there cognitive decline in these patients? We see, again, that impaired group in particular, that neurodevelopmental group looks to be the one that also shows the greatest level of change after the onset of disease. We see minimal but noted change in that middle selective impaired group, and that'll be important when I get to biomarkers. But that intact group actually improves over time. And so again, just noting that what these suggest is that some patients with bipolar disorder show a declining course and other patients do not. When you lump them together, you lose that signal completely. So we revised that initial model of kind of the cognitive development based on these subtypes and really point to the fact that this should be in color. The purple line would be that resilient course noted on the top. They show normal premorbid functioning. They show resilience to cognitive change over time. There's that middle group, which would be the red one, that actually looks more like that typical neurodevelopmental hypothetical model, where you see normal premorbid functioning and then a sort of declining course over a period of time after the onset. And then there's the neurodevelopmental looking group, which would be the blue dotted line at the bottom, where we see abnormal premorbid functioning as well as cognitive decline after the illness. So the next important question is, can we use this information to identify modifiable risk factors in order to think about intervening here, which is really the period where the window of opportunity presents in terms of trying to get everyone's course to look like that top line. So when we use this and we think about these particular subtypes and look at how they differ after the onset of disease, this is the area where we start to think about what can we modify or improve in those individuals. First is the most straightforward one, which I've talked about a few times already, is the recurrence of disease. So numbers of manias in particular. And what we see is what we expect to see based on the evidence in the field thus far, which is that there's an increased number of prior manic hospitalizations, so severe manias, both in the impaired group and in the suboptimal group, that red group in the middle. The intact group has the fewest number of prior manias. And remember that I mentioned that these patients have a similar duration of disease. So the red and the blue group have just had a higher recurrence rate. They're having more episodes than the purple group. And so this is obvious. This is an intervention point that is what every clinician who treats the disease does, try to reduce episodes. But it does point to the fact that something is happening during these manic episodes that is likely contributing to the change in cognition in people with bipolar disorder. The data on depressions here is in the direction you wouldn't predict. It's also not significantly different by group, but that intact group is more commonly showing depressions than manias than the other two groups. When we look at comorbidities, we see that there's no difference in anxiety disorder comorbidities over the lifetime, but we do see, as I noted, very high prevalence of comorbidities. So all three groups have, between 40 and 50% of comorbidities with anxiety disorders. In contrast with substance use disorders, when we do the lifetime diagnosis of substance use disorders, the intact group is the one who shows the least number, where suboptimal and impaired look similar and have higher rates of substance use disorder over their lifetime. When we look at sleep, we're looking at just a self-report, Pittsburgh Sleep Quality Index, a PSQ. We're asking patients how their quality of sleep is right now. And this is just one of the indices on this. I think this is actually the total score. But that black dotted line is the mark of what we as clinicians think about as being abnormal. So anything above that, people are reporting problems with sleep. So I'll just point to the fact that everybody is reporting problems with sleep and remind you that these are remitted patients. So this is an area of incredible interest from an intervention standpoint. But we do see that the suboptimal impaired group are significantly higher in rating. This is deficits are higher in this case. So they're reporting more problems with sleep than the intact group. So all of these things I've talked about from a behavioral standpoint are potential modifiable treatment targets. They should be considered outside of just treating the acute mania and acute depression. Really think about sleep quality and substance use, the comorbidities, and really reducing episodes whenever possible. those are the behavioral targets. I'm going to talk now and shift, I think, for the rest of the talk about biomarkers and where we might think behaviorally and biologically we can intervene to improve cognition or to at least decrease the amount of cognitive decline. So inflammation, this is kind of a busy slide. I'm not going to walk through all the details here. I've already mentioned what we think is happening, and there is cross-sectional evidence that suggests this. Very little longitudinal evidence still. But what we see is cross-sectionally, groups of patients with bipolar disorder, when they're acutely manic, you see upregulation of many of the pro-inflammatory cytokines seen on the second row there, TNF-alpha, IL-6, some of the measures that are pretty commonly used when looking at inflammation. And you see that early in the disease, that this will go up. And then when the patient remits, those markers come down and they recover. And then they have another manic episode. And the markers go up again, and then they come down on recovery somewhere around, and this is kind of arbitrary, but somewhere around the fifth mania, they don't recover completely. And so you'll then see low-grade chronic inflammation for the rest of that patient's course of disease. This is believed to be sort of recognizing that cumulative burden that's happening over time, and is one of the bigger markers of why we think neuroinflammation is not only contributing to that, but is also an important treatment target to stop that change over time. So I'm going to show you data from one of these markers today, TNF-alpha. You're probably mostly familiar with this. This is one of the most widely studied and is a key component of the innate immune system. We took this in the periphery, so these are serum-based markers. This is thought to determine the severity and duration of an inflammatory response. And as I mentioned, this is one of the markers that you see elevate during mania, and then also in many cases depression, and then recover until later in the disease. And during late stages, somewhere around episode number 5, you see a consistent picture of chronic inflammation. So this marker follows that course. If that's true, we would expect in the data that we have that this would be associated with cognitive decline later stages of the disease. And this is a paper we published, I think, about 2 years ago now, where we looked first on the left side at correlations between TNF-alpha and its soluble receptors and cognitive functioning. And so you see basically here correlations that higher levels of TNF-alpha are associated with impaired cognition, specifically in executive functioning. Again, these are people who are remitted, so they're not in an acute illness. But over here on this side, and this isn't a particularly compelling graph, but there is a statistically significant difference between early stage and late stage patients, suggesting that once you've had 5 episodes, your TNF-alpha is higher than those individuals who have not had 5 episodes. So just consistent with the data that's already out there in the field. We did a path analysis and looked for mediation to ask the question, does peripheral TNF, and in this case, it's an index of all 3 molecules, does it mediate the relationship between prior episodes, severe episodes, and current cognitive functioning? And here we see, yes, it does. So it is a significant mediator. This just suggests, among probably many others, that TNF is likely a treatment target, and thinking about how we can stop that cumulative change over time. How we do this, and if we do it as straightforwardly as that sounds, is complicated by the immune system and the way the immune system works. It is extremely complex. So in many cases in autoimmune diseases, you give a TNF-alpha blocker and it makes people worse, even though they have elevated TNF, because there's questions about what the source of the elevation is and the best way to approach it. So the simple thing here would be to start a trial and try to block TNF-alpha in those people who have elevated TNF-alpha, but it's not that simple. So I'll talk about the sort of deeper dive we're taking in trying to understand some of these outcomes that we're seeing. Also worth noting, it's not applicable to all patients. So not all patients have this kind of elevated inflammatory marker profile. When we look specifically at that same cohort that I just talked about, when we look at cases versus controls, we take all the patients together, we compare them with controls. There's no difference in TNF-alpha. If we stopped there, we would suggest inflammation's not a target, leave it alone. People with bipolar disorder don't have elevations on this marker. But when we look at the cognitive subtypes and we're looking at how people, these subtypes that are again grouped more specifically on how their brains are functioning, we see a different picture. Both the suboptimal and impaired have elevated TNF alpha, and actually the intact group have slightly lower levels of TNF alpha relative to healthy controls. I'll note that the red group has the highest significantly relative to even the impaired group, and that's important because I think I noted out loud, but on the graph, that's also the group that's had the most prior manias. Again, suggesting that this may make sense within that hypothetical model. So this tells us not all patients have elevated inflammation, at least based on this marker, and that it may only be a treatment target in some people. And this has become clear in some of the early trials, mostly in major depression, less so in bipolar disorder, where anti-inflammatory agents have been given and failed. So the trial didn't work. But then secondarily, they went back and looked at baseline levels of inflammation. And those people who had elevated inflammation did well on the treatment. And those people who did not actually got worse. And so it's an important point in terms of just thinking about enriching samples and who you treat with these kinds of approaches and who you would not want to treat with these approaches. So just to kind of summarize the phenotype picture of these different groups and think about the way in which this implies how we should more precisely target specific areas in each of these groups. That intact group was doing better on most things, but they have the highest rates of depression. What I didn't show you is they're 3 times more likely to have made a suicide attempt already, again, with the same duration of disease. So this is more kind of consistent with a kind of depressive subtype of patients. They also have lower levels of inflammation and probably would not do well with anti-inflammatory targeting. The suboptimal subtype does have the highest level of mania. They have poor sleep. They have the highest level of substance use disorders and the highest level of inflammation. So there's a number of targets we might think about within that subtype. And then the impaired group, who is seemingly has some abnormalities neurodevelopmentally, also reports poor sleep. They use tobacco more often than the other groups do, but a relatively normal level of substance use disorders. They do have the highest rate of anxiety and elevated inflammation. Again, really trying to kind of parse this out and how these subtypes might be then informing precision care. So quickly I'll touch on, and then we're gonna hope to have some time for questions. Quickly, I'll touch on some of the next steps. This is the deeper dive we're taking from the immune system standpoint. I've already mentioned the model, which is why we're looking at the immune system more specifically. The blue that you're seeing here are things we've already done. I didn't report on thyroid. I've got, I think, some hidden slides if people are interested in that, if the time permits. But we've published on CRP and TNF alpha and part of the immune, just the cytokines and sort of peripheral cytokines in the blood. What we have now new data on, which I'm showing in red here, not yet published, are RNA-seq. This is whole blood RNA-seq, not single cell. So it's a broad screener, but looking at gene expression levels in a subgroup of those patients. We also have epitope level autoantibody profiles looking across particular antibody markers in the same cohort. And I should also say in these, we are now longitudinally following these individuals. So we have these at multiple time points. We're also looking at cell-specific abnormalities. And this is done by isolating PBMCs and storing those for phenotyping. We've done a little bit of phenotyping on them so far, and it does look specifically like there's a shift in the profile of T helper cells, really suggesting that and actually I should mention overexpression of TNF alpha from CD8 cells. So an important piece of the puzzle in thinking about what is causing the elevations in TNF alpha that we've reported already. And then the next in line, what we're looking to do now is to use the rest of the PBMCs to design and develop, to grow iPSCs. And we've just gotten funding from the Breakthrough Discoveries for Thriving with Bipolar Disorder initiative to allow us to do some of this work, as well as testing immune cell flow through a brain chip with a vascular component and testing blood-brain barrier. So a lot of additional things we're doing with these. That I've got some, again, hidden slides and some of the data, but wanted to save some time for questions. The last thing I'll end on, I'm obligatory as the scientific director for this new initiative, looking at, really it's a new nonprofit that's funding research in bipolar disorder, and want to kind of point to the importance of, I think, the work that I showed you, but as a single lab doing this with relatively small samples, we can only take this so far. This initiative, in particular, this integrated network piece of it, will scale up all of what we're doing, including things like imaging, into a very large scale longitudinal study of 4,000 people with bipolar 1 disorder over at least 5 years, where we're meeting with people every year, doing a lot of biomarkers, a lot of behavioral phenotyping, as well as imaging. And we're tying this into a learning health network, so EHR records and point of clinical care data as well. I won't get into that. There's a lot of details to say, but just to say that I think the time is now for expanding what we've been doing and what other groups like myself have been doing to really scale this up and to make sure we're looking at it across time in people with the disease. So I'll conclude just by noting, again, the dynamic and complex and heterogeneous nature of the disease. It has been something that has caused a slowing of progress in understanding the etiologies of the disease and improving care for patients with bipolar disorder. But we may be able to leverage this heterogeneity in certain ways using these different statistical approaches and acknowledging that subtypes may exist to inform more precise care for each patient with the disease. I showed you today, and there are others out there, but many factors that contribute to good versus poor outcomes in people with this illness. And the behavioral ones include episode reduction, sleep improvement, substance abuse interventions, and then there may be some novel biological ones. And these are still early data. Again, probably too early to jump into a clinical trial, though people probably are doing so at this point. Anti-inflammatory approaches based on the inflammation markers I mentioned, potentially immunotherapies based on some of the autoantibody work that I didn't get a chance to present today, as well as metabolic targets. Again, didn't present the thyroid results, but there are some clear treatment targets within that biomarker range as well. And the goal of the work, of course, is to identify those people who are at the greatest risk for poor functioning and to intervene to optimize outcomes for every patient with the disease. And really, I think, again, at the level of the field, through increased collaboration and long overdue dedicated resources, new global initiatives promise to move this needle on this very disabling disease. Thank you, and I think we have time for some questions.
Thank you so much for that talk.
Sure.
Very interesting work. I had two questions. The first question is whether you think that intervening, by the 5th manic episode would rescue cognition if you were to deliver an immunotherapy or otherwise, or whether you think that this is more of a preventative thing once you get your first, second episode. And then the second question is, it looks like there might be some element of maybe immune memory or innate training, such that every episode you have an increased maybe type 1 inflammatory response. And I'm wondering what you think about things like epigenetic changes and HDAC inhibitors and things like that.
Yeah, great questions. Well, I'll start with the first one. So I think that there is a good chance that some of these things can be reversed. I will say what is sort of an interesting thing as a person who's sort of bridged the schizophrenia field and bipolar, particularly earlier in my career. From a cognitive intervention standpoint, I've always kind of made the argument that cognition is more tractable in bipolar disorder because the deficits start later in life. Now, what I showed you is obviously not true for at least a subgroup of patients with bipolar disorder, where you see the abnormalities probably similar to those seen in schizophrenia early in life. The reversibility of cognitive deficits, in my mind, is going to be easier in someone who had intact cognition up to the point of the episode's beginning. From a targeted standpoint, I'm not sure if it would rescue the immune changes that are there. I would assume yes, and therefore it would help with the cognitive piece of it. The preventative piece is more where I think that the opportunity is, which is is even true using things like lithium, to be honest, where we know in animal models it's neuroprotective. It's less about it may also be anti-inflammatory, but I think there's also some data it's inflammatory. So sort of pointing to the idea that if there are things that protect the brain, and we know they do, that the kind of earlier adoption of that in the course of disease makes a lot of sense. People ask about kind of the existing repertoire of medications, and if my child had bipolar disorder, I would likely have them on lithium if I could push for that. There's problems with lithium, and so the idea of finding other novel approaches to prevent these kind of deleterious effects of the episodes, I think, is important. The other thing, which I'm not sure I have the answer to, but I think is worth making a point, is whether you would only intervene during acute episodes with an anti-inflammatory approach to just knock down the initial, upregulation of these markers when they're happening, and hope that would be enough to sort of stop that cumulative effect, versus having someone on an anti-inflammatory or immune modulating therapy consistently over time. These patients are on a lot of medications, and so but I think protecting the brain is a really important thing for everyone. It is one of the things that at least many clinicians who I've talked to, patients are more likely to agree to take medications and stay on medications if they're targeting cognition as opposed to mania. And that's a whole complex thing. But the second question, immune modulators, HDAC, yeah. So I think the data are too early to start to think about. I mean, from an HDAC inhibitor standpoint, there are a lot of potential bad side effects of some of those medications that I think, again, in about 5 years, my guess is we'll have enough information, even just from this BD squared initiative that I mentioned, to start to think about some more specific targets in the immune system.
Incredible talk. Thank you. Can you just give a take-home message around the thyroid functioning data? It just seems like such an easy point of entry, something that many patients might already have in their chart. So very curious about that. Thank you.
Yeah. So this is one of the bigger bits of the data. I won't walk through the entire thing because I know we're only 7 minutes from the end, but what we looked at were a bunch of thyroid markers in the blood of, this is that first cohort that I showed you. It was cross-sectional, where we looked at TSH, we looked at free T3, total T3, T4, free in total, and we looked at some of the antibodies. What we found, broadly speaking, is the elevated free T3 in the blood is good for cognition, and more specifically, it's good for emotion regulation measures, which are related to attentional bias. So people who have bipolar disorder and depression will have an exaggerated attentional bias, which is implicit. The brain does it automatically toward negative information. It's a risk factor for the disease. It's a risk factor for recurrence. Some antidepressants will shift that attentional bias when they're effective. So we know that there's something about that is driving the depressive profile. T3 is associated with a differential happiness attentional bias. So the shift away from negative toward positive information. Now, in bipolar disorder, that's complicated because you also see that during acute mania. These are remitted individuals, but the suggestion here and what these data are showing is that this particular group of even euthyroid, so these people I should have mentioned are all pretty much within the normal range of thyroid markers, but even within that range, higher levels of T3 are good for both mood-related components and cognition and the intersection of those two things. So I think, this is, I'm not a thyroid expert by any means, but I know there's controversy just more broadly in the field of what's the right measure of TSH before you intervene. This just suggests that this should be an area that clinicians are paying close attention to in the patients and optimizing thyroid levels.
Hi, thank you. Great talk.
Yes.
I'm wondering, are there any neuropaths findings or studies or even more structural imaging studies? Because it makes me think, is this a cognitive reserve issue that particularly in light of the adverse early events, poor education? So is it just a vulnerability, or is there an active physiologic process, synaptic changes, microglial activation, et cetera? Because those would, point to very different treatment or prevention.
Yeah. So great question. There are very little neuropath data, very little, although I will say that the BD Squared initiative that I highlighted right at the end has funded the Common Mind Consortium to do a lot of very cool molecular phenotyping and postmortem brains that hopefully will tell us a little bit more in a year or two. But the imaging data are a little bit more consistent. I'll note that remarkably few good longitudinal studies, but cross-sectionally, it's pretty clear that you see a loss of gray matter. There's some white matter changes as well, but the gray matter in the areas of the hippocampus and prefrontal cortex, Enigma and some of the other large consortiums have shown pretty clearly that happens after the onset, and that it does correlate with numbers of manias. These are all correlations because it's cross-sectional, but I think there's enough evidence that that's happening. The other bit of evidence that's worth noting is that lithium protects from that. So whether or not you're a lithium responder, if you're on lithium, those areas of your brain are in some cases bigger than healthy controls, but they're not smaller. And so we do see these are all markers of something happening after the onset of disease. There's less, I think, neurodevelopmentally. And again, I think with the idea, and my group's not the only one doing it, but the subtyping component, I think that it will become clearer that there are a subgroup of patients that will show some of the neurodevelopmental abnormalities, both from an imaging and a neuropath standpoint that you see in schizophrenia and in autism and some of the clearer neurodevelopmental diseases.
Thank you so much.
Sure.
Got all microphones everywhere. A question I had that this might based more on my clinical observation. Has there been any efforts to subgroup the people with bipolar disorder into those who have a more classic pattern versus those who don't? And so what I mean is, it seems to me as a practicing psychiatrist that you do get a bunch of patients who fit into a pattern of they have mania and then depression. It's a very distinct pattern. And I'd say it's a fairly large proportion of the patients with bipolar disorder. And those patients seem to do better. Maybe it's easier to predict their episodes. You can convince them to take meds because you want to try to help prevent manias that will then subsequently prevent the depressions, which is the key hook for patients many times.
Yeah. Another great question. So yes, I think most of what we know about that comes from treatment studies and the way, as you point out, some people are more or less treatment resistant. The kind of classic bipolar presentation with the full clear acute mania, usually with some psychosis, and that being more prominent. That the textbook version also responds better to lithium, which is non-trivial in the space of what we can use to treat this disease. If you're an excellent lithium responder, you're in very good shape from the standpoint of bipolar disorder. And that is more typical of that phenotype. There's not a lot of other evidence that suggests that even things like psychosis predict whether someone responds better to an antipsychotic in this illness. So the courses, the difference between bipolar 1 and bipolar 2 and predominant polarity, where some patients are almost always in the manic phase and others are almost always in the depressed phase, there's not a lot of real evidence that suggests what you should do in those cases. And I think that comes back to the original way in which we define these by checklists and by symptoms and what you're seeing as opposed to what might be happening in the brain. And I do think that those will map on to some of the approaches that are being used to subtype. Interestingly, they don't map onto the way that I did it, where you've got these cognitive subgroups and it really, like bipolar 1 versus bipolar 2 psychosis, really didn't, it wasn't what was sort of driving the differential between those groups. But I suspect that will continue to contribute. The subtyping, the clinical subtyping thus far hasn't told us enough, I think.